Good evening, everybody. I welcome you all to the fifth webinar of the Young Professional Forum ISTM Academic Initiative. We have the pleasure of having with us the entire team of Young Professional Forum, and I will hand over the reins to Dr. Ankit Mathur to carry on this academic feast forward.
Good afternoon, good evening, everybody. I welcome you all on behalf of ISTM Young Professional Forum. And as usual, we have a very good topic to discuss today. And this topic is transfusion-associated GVHD and transfer-related immunomodulation. To chair this session, we have Dr. Aseem Tiwari and Dr. Prashant Pandey. And speaker for this talk is Dr. Divjot Singh. Dr. Aseem Tiwari, I would like to welcome Dr. Aseem Tiwari. I hope he has joined.
Yes, Ankit.
Hi. Okay. Hi. So Aseem sir is working as director in transmedicine at Vedanta Hospital, Gurgaon. He is MBBS and MD from Kanpur Medical College, and he was trained in transfusion medicine in Lucknow. And he is reviewer of many journals. He has several publications, and we all have heard him many conferences. He's a very good teacher, and he has received several awards, including HD Shorey Award from ISBTI, and he is currently as Joint Secretary at ISDM. I would like Dr. Aseem Tiwari to say a few words about YPF, and then we will start our program.
Good evening, everyone. I'm glad that Young Professional Forum is doing a very credible job of organizing very frequent meetings, and the fact that this is the fifth webinar, itself says a lot about the Young Professional Forum. Congratulations to the Young Professionals Forum. We are very proud of the YPF, Young Professional Forum of ISTM. And I would also like to share with people who may have joined for the first time that there is also provision of getting a certificate. So there would be a link, and anybody who's interested in getting a certificate should register on that link with their name and other details. And they would also receive a certificate of such academic activity. Please carry on the good work that you have been doing. Thank you very much.
Thank you, sir. Second chairperson for today's program is Dr. Prashant Pandey. I welcome Dr. Prashant Pandey, and he is MBBS and MD MD in Transfusion Medicine from SGPGI Lucknow. Currently working as additional director and head of transfusion medicine and transplant immunology at JP Hospital, Noida. And he also has several publications. And I just want to mention from various WhatsApp groups, I came to know Dr. Pandey has utilized this several months in writing several papers and several publications. Itself is an inspiration for all of us how to make use of the timing. So with this, I welcome Dr. Prashant Pandey, and I would like him to say a few words about IPF. Then I request him to introduce our speaker of this the webinar today. Over to you, Dr. Prashant Pandey.
Yeah, thank you very much, Ankit. What about IPF? I came to know about that the topic what you have selected is really very good for the young professionals, and particularly the topic of today. This is one of the most important topic for those who are appearing in the exam, and they are going to appear in the exam like DMD and DMD candidates. And this is one of the most favorite topic for the teachers actually, because these two topics are not the chapter, they are the complete book in itself actually. So definitely for today's topic, I think it's going to be a big challenge for the speaker to complete in 30 to 40 minutes, because the audience must be having a lot of questions about these topics. So with these words, I would like to again congratulate the team of YPF for organizing it in such a nice way. With these words, now I would like to introduce Dr. Lamba, Dr. Divjot Singh Lamba, who is working as assistant professor in the Department of Transplant Medicine, PGI Chandigarh. This is one of the most reputed institute of India. And here, I think he is working from January 2017. So for 3 years, he is working as assistant professor. Before that, he completed his MD in Transplant Medicine from the GMCH Chandigarh in 2012. So he is having almost 8 years of experience in transplant medicine, post MD experience of transplant medicine. He is a recipient of various awards like the Best Paper Award, Poster Award, and one of the best reputed award is the Herald Bunsen Fellowship Award in 2013 December ISBT that was organized in Malaysia. He is also having almost 10 papers published in various international and national journals. And his area of expertise is basically the transmitted infections, quality in TTI. His area of expertise in the platelet pheresis and therapeutic hemopheresis. He is having a lot of interest in donor motivation, recruitment, and how to increase the voluntary blood donation in society and its complexities. With these words, I would like to invite Dr. Lamba to start his topic. But before starting his topic, I would request him to finish at 30 to 40 minutes of timing so that the audience is having a lot of time to discuss about these two sort of topics. Now, the mic is handed over to Dr. Lamba to start the presentation.
So I first of all thank Dr. Asim and Dr. Prashant for giving me this wonderful opportunity to present the topic. It's a lengthy topic and I'll try my best, sir. And with these words, I would start. So coming to transfusion-associated graft versus host disease, I hope I'm audible and trim.
You're audible, loud and clear.
Thank you. So we'll be discussing the transfusion-associated graft versus host disease in this order: overview, background, pathophysiology and mechanism, risk factors, and patients at risk for transfusion-associated graft versus host disease, clinical presentation, diagnosis, treatment, and prevention, and a few case reports. So overview, it's a clinical syndrome occurring from 2 days to 6 weeks after cessation of transfusion, characterized by characteristic rash, edematous maculopapular eruptions centrally that spread to the extremities and may in severe cases progress to generalized erythroderma, hemorrhagic bullous formations, diarrhea, fever, hematomegaly, liver dysfunction, marroplasia, pancytopenia, and characteristic histological appearance of skin and liver biopsy. So it's a rare complication and occurring due to transfusion of lymphocytes containing blood products. So leukocyte dose would matter and the age of the blood component. Clinically similar conditions are we see in bone marrow transplant patients and hematopoietic stem cell associated graft versus host disease. Though we will be discussing that this is more severe. Usually it arises in 4 to 30 days after transfusion, and onset of symptoms occur early with signs and symptoms of bone marrow aplasia. 50% of the transfusion-associated graft versus host disease in patients who these occur would not be predicted to be at risk for TAGVHD, and thus the products would not be irradiated. So there are various studies we'll discuss. Then donor lymphocytes who have HLA antigens that are shared by the recipient dominate in these cases, particularly in the immunocompetent cases. So then coming to background. So whenever the immunologically competent cells or precursors are introduced into an immunologically crippled patient, so there is a possibility of GVHD. So we'll first discuss a little about GVHD. So this is a phenomena in which donor T cells responding to the proteins on the host cells proliferate and target the host organs, primarily the skin, liver, intestinal tract, and bone marrow. And immunologically competent cells can be introduced in hematopoietic stem cell transplantation, transplantation of solid organs, as well as through transfusion of unirradiated blood and blood components. So the biology of graft versus host disease, it would depend on how much the graft is immunologically competent. There may be antigenic differences between the donor and the recipient, and the recipient must be unable to mount an effective immunological response to eradicate the transplant immunologically competent cells. So these are the Billingham criteria, as they are known as. And first, the pathophysiology of graft versus host disease. So in graft versus host disease, sorry, uh, basically there are three steps. First is the conditioning of the host. So it would be by chemotherapy and radiotherapy, which would lead to tissue damage. So this would allow the lipopolysaccharides, like in this case from the intestine, stimulating the secretion of inflammatory cytokines such as IL-1, IL-6, tumor necrosis factor alpha. In second step, cytokine stimulated host antigen presenting cells present the host antigen to the donor T cells, resulting in activation of donor T cells, so which have a predominant Th1 phenotype, which would secrete the interferon alpha, which is inflammatory, and IL-2. And in step 3, the effector cells, that is the cytotoxic T cells and natural killer cells, which are then stimulated, induce the target cell apoptosis both by direct cell mediated as well as secretion of the inflammatory cytokines. So then how the donor T cell activation can take place. So once the donor T cell get activated, so there are basically three arms which can be generated of the T cells. Th1 pro-inflammatory cells, which would secrete the inflammatory cytokines like IL-2, interferon gamma, tumor necrosis factor. Then there is an anti-inflammatory Th2, which would also lead to secretion of transforming growth factor beta, which is anti-inflammatory, and various other factors which are anti-inflammatory, and regulatory cells, which also have a role in decreasing the inflammation. So this is the paper from basically immunomodulatory aspects of transfusion. So it shows various changes which take place when we transfuse the blood into the and the changes which take place in the donor and the recipient T cells. So why we are discussing GVHD? GVHD, it would help in controlling once the transplant take place. So it would also help in improving survival in allogenic stem cell transplants due to immunotherapeutic consequences. So best protection against leukemia, reoccurrence in patients with GVHD, and if the GVHD is not taking place, it can lead to reoccurrence of the cancer. So then pathophysiology of the TB transplant associated GVHD. So when the donor is homozygous and the recipient is heterozygous for HLA class 1, the host will not recognize donor lymphocytes as foreign. So this is a diagram which is depicting the donor HLA, so which is homozygous, and the recipient is heterozygous for the HLA antigens. So the recipient will recognize the donor as a match, whereas the donor will mount an immune response against the HLA antigens, which are not same to the donor. So this would occur in the immunocompetent host. In the immunocompromised host, these T cells, donor T cells, would engraft and mount an immune response. So what are the various mechanisms involved? So first, the host antigen presenting cells will present the host antigens to the donor CD4, HLA class 2, and cytotoxic CD8 cells. So these recognize the host HLA antigen as non-self. So these are the mechanism by which the donor T lymphocytes will proliferate in the recipient. So the host APC would present to the host antigens, then activation of T lymphocytes, proliferation and migration, which would be by various chemokines. Then there is massive release of TNF alpha, IL-1 and IL-2, which are inflammatory factors, to the Th1 response. So TNF alpha is the key inflammatory cytokine, which would activate the dendritic cells, recruitment and activation of T lymphocytes, and cause the target cell apoptosis, directly causing tissue damage. This would also cause a cytokine storm, that is widespread tissue damage would occur, manifesting as skin rash, abnormal liver function, bone marrow plasia, target organ damage by various soluble inflammatory mediators, and cytosis. So there would be two effector pathways which can mostly two effector pathways take place. First is the fast ligand pathway. So in this pathway, the cytotoxic T lymphocytes which were activated of the donor. So these have fast ligands which would attach to the fast receptors of the target cell. So this would form a FADD, which is a death domain. Then it through various caspases, this would cause apoptosis of the cells. Then the second pathway is the perforin granzyme pathway. So in this, the cytotoxic T lymphocytes would uh, secrete granzyme and perforins. So a transmembrane pore forming molecule which would promote the entry of these cytotoxic granule serine proteases called granzymes. The granzymes have the ability to cleave proteins at aspartate residues and activate a variety of the cellular caspases. This would again lead to apoptosis. So basically cell damages occur. So what are the various factors which promote the development of transfusion-associated graft versus host disease when we transfuse the patient? So it would depend on degree of recipient immunodeficiency. So the inability to reject the donor T cells, which is the main factor, the number of viable T cells in the transfusion, and in immunocompetent hosts, genetic diversity in which the donor is HLA homozygous and the recipient is heterozygous. Then it can also occur in few studies. It has been seen in mostly in cardiac bypass surgery and transfusion of very fresh blood, which would have active lymphocytes. So what is the dosage of viable T cells that would mount a response of TAGVHD? So minimum number of leukocytes required to cause the disease. So there are various studies. So some studies indicate that even fewer than 10⁵ T cells per kg of the recipient body weight. These are usually safe. And usually the dose of transfusion which would mount a response of TAGVHD is 10:7. But in some studies, as low as 10:4 T cells per kg have also been seen to cause the TAGVHD. So the exact dose is not known. Then HLA homozygosity is one factor in the immunocompetent host. So partially matched HLA donors. So basically these could be from the family donors or a homogeneous population like Japan. So this is a study in which frequency of HLA homozygous donors in various population was seen, and in Japan, the parent child homozygous donor to the potential heterozygous recipient is 1:1:102. So this is the most genetically homogeneous population, so where universal leukoradiation irradiation has been uh, promoted from quite a long time. Then in cardiac bypass surgery, there is an increase of risk of transfusion-associated graft versus host disease. So this is due to decreased mitogenic lymphocyte transformation factors. Mitogenic lymphocyte transformation factors decrease production of cytokine TNF alpha and IL-2, and TAGVHD has been seen following extracorporeal membrane oxygen use. In fresh blood, which contains a maximum number of viable lymphocytes, blood less than 4 days old, lymphocyte viability is retained in stored blood for 3 weeks, and during storage, a number of viable lymphocytes decline, as does the expression of cell surface lymphocyte activation antigens. So fresh blood would have more chance of causing the TAGVHD. Who are the patients at risk? Recipients of donation from first or second degree relative, patients mostly first degree relative, patients receiving HLA matched components, immunodeficient patients like SCID patients, severe combined immunodeficiency syndromes, then intrauterine transfusions of red cells and platelets. So these would all be the indications in which, if we want to prevent the TAGVHD, subsequently we will see these are the indications for irradiation. Red cell or platelet transfusions who had in vitro transfusion up to the age of 6 months. Then Hodgkin's disease, patients treated with purine analogs following anti-CD52, various immunotherapies, and aplastic anemia patients receiving immunosuppressive therapy like anti-thymocyte globulins. So also the patients at risk are allogenic stem cell transplants from the time of initiation of conditioning chemotherapy until the GVHD prophylaxis is completed. Following stem cell transplant, if chronic GVHD or if continued immunosuppressive treatment is there, irradiated blood component should be given indefinitely. And patients undergoing bone marrow or peripheral blood stem cell harvesting for future autologous transplant should also receive irradiated components 7 days before the bone marrow stem cell harvest and afterwards to prevent the collection of viable allogenic T lymphocytes, which can potentially cause the TAGVHD, as these also withstand the cryopreservation. All patients undergoing autologous bone marrow transplant or peripheral blood stem cell transplants from the initiation of conditioning until 3 months post-transplant. So 6 months if total body irradiation has also taken place initially. So who are the patients not at risk? Solid organ transplants, HIV, solid tumors, routine surgery, premature or term infants unless there has been an IUT previously. So these are perceived not at risk, and minimal risk is for acute leukemia, non-Hodgkin lymphoma, like I've enumerated. So what are the clinical presentations of TAGVHD? So signs and symptoms will usually begin 4 to 30 days after transfusion. Initially, fever with skin manifestation would take place. Then GI manifestations, hepatic dysfunctions, bone marrow failure with pancytopenia. Death often occurs with infection or bleeding manifestations. So the diagnosis is usually supported by skin or bone marrow biopsy appearance and or identification of donor-derived cells, chromosomes or DNA in the patient's blood or affected tissues. So this is just a diagrammatic representation of the symptoms, signs and symptoms of TAGVHD. So in immunocompromised states and partial HLA matching, so donor T lymphocytes against the recipient antigens, so which will cause engraftment and proliferation of the CD4 and CD8 T lymphocytes, which would lead to systemic inflammation. Then infiltration of systemic tissues, which will lead to skin rash, erythematous, characteristic erythematous maculopapular rash, abnormal LFTs and GI symptoms, then pancytopenia, hypocellular marrow, and death. So one major difference between GVHD and TAGVHD is pancytopenia is there, and which is almost fatal. So skin manifestations are erythematous maculopapular rash, a pruritic rash, which would involve the palms, soles, spread throughout the body, and blisters and ulcers in severe cases. So there is lymphocytic proliferation under the skin and biopsy. Then what are the differential diagnoses which we can think of? So acute seroconversion illness due to HIV infection could be one of the differential diagnoses. Then acute viral hepatitis can present with similar illness if it is associated with progressive rising AST and ALT levels, severe drug reactions, dengue fever, and leptospirosis. So basically, its diagnosis is probably underdiagnosed since it may wrongly be attributed to other differential diagnoses as have been discussed. And histopathological hematological features and detection of the donor lymphocytes or DNA, that is mixed chimerism, is the proper diagnosis. So in histopathology of skin, so various changes can be seen, that is apoptosis at the base of the epidermis, then diskeratosis, exocytosis of the lymphocytes, so satellite lymphocytes adjacent to the diskeratotic epidermal keratinocytes. So these are the various changes as have been depicted in the figure. So basal vascular change, sparse lymphocytic proliferation of the dermis. Then in GI, so the diarrhea, secretory and volumous greater than 2 liters per day, bleeding, life-threatening intestinal hemorrhage, nausea, vomiting, anorexia, abdominal pain, and histopathologically apoptosis of the crypt epithelial cells, lymphocytic proliferation, patchy ulceration, and loss on flattening of the surface epithelium. In liver, there are various manifestations. First, the clinical patient would present with jaundice and hepatomegaly. Then in laboratory, increased liver enzymes and increased serum bilirubin. So mainly cholestatic hepatitis would take place, which would damage the bile duct epithelium, bile duct damage, portal and Doppler inflammation, and various other changes. So characteristic diagnosis in the bone marrow. So marked hypoplasia or aplasia. So with numerous macrophages and erythrocyte precursors and loss of the cellular milieu. Then lymphohistiocytic infiltrate. So these are the findings. So this is the aplastic, basically aplasia in the bone marrow histopathology. Then characteristic diagnosis would take by detection of these donor lymphocytes. So techniques to establish donor lymphocyte engraftment are based on genetic differences between the donor and the host. So HLA typing, chromosome differences, and DNA fingerprinting, then fluorescent in situ hybridization. These are various techniques by which the donor chimerism can be detected. Detection of small genetic differences in highly polymorphic regions. So this is a comparison of the GVHD following hematopoietic stem cell transplantation with transplant-associated graft-versus-host disease. So in comparison to the GVHD, pancytopenia is almost always there, occurrence is rare, and response to therapy is also rare. So mortality would be 90 to 100%. So these are the case reports from our center where transfusion-related adverse events at the tertiary care center in North India. So TAGVHD is quite rare. Only one case was reported in 2011. And another case report from pediatrics department, 2 cases were reported in 2006. So in Hemovigilance Program of India, which analyzed the transfusion access, so there was a paper in which 3-year data was analyzed. Only one case was reported. And various case reports from India. So there are 4 or 5 case reports from India and 4 or 5 abroad. And you can find various review articles, but case reports are less. So coming to the treatment, so very poor prognosis, almost invariably it is fatal. Treatment options would include high dose steroids, then chemotherapeutic agents like azathioprine, methotrexate, cyclosporin, intravenous immunoglobulins, and definite treatment by hematopoietic stem cell transplant, but mortality is quite high. And ECP, as far as I have searched, it has not been tried in TAGVHD, but various uses have been there in treatment of acute GVHD and chronic GVHD, probability due to the high mortality. Then coming to prevention of transfusion-associated graft-versus-host disease. So blood irradiation is the prevention. So treating the cellular blood components, all the cellular components with minimum 25 Garai of gamma irradiation, which inactivate the donor T lymphocytes across by causing cross linkage of the DNA, and there is no damage to the platelets and granulocytes. The effect of irradiation on red cells would include increased plasma permeability with potassium leakage, hemolysis. But this is the prevention, how we can prevent the TAGVHD. So it's a preventable disease, and the optimum prevention strategy is primarily because of the. So there are various controversies which exist, and universal blood radiation will eliminate TAGVHD, but it is not feasible. Over the past 10 to 15 years, use of irradiation in high-risk situations has reduced its incidence, especially in the Western world and Japan. So targeted approach is to irradiate blood to be transfused in patients who are at risk. So irradiation and other strategies, X-ray radiation, which has less initial cost, less radiation hazards, and more maintain, but though maintenance is more. So this is a short data in which before 1999 there were many cases of transfusion-associated graft-versus-host disease. All were fatal. So after introduction of universal radiation, it has reduced even in the USA. So there are various indications of irradiation. So blood components from the first degree relative, HLA compatible blood components, IUT, neonatal exchange transfusions. So these are various according to different countries they follow. Then congenital T cell immunodeficiency defects, allogenic BMT or PBSC transplant patients, patients with Coskins disease, patients treated with the purine analogs. Then irradiation of the blood component is not recommended for acellular components like fresh frozen plasma, frozen or thawed RBCs, cardiovascular surgery patients, then patients with solid tumors and solid organ transplants. So what are the other options to prevent the GVHD? So pathogen reduction technologies have been utilized in various studies to know its efficacy for reduction of TAGVHD. So so this is a paper regarding approach used for pathogen reduction technology, that is amoxicillin and UVA, to decrease the incidence of TAGVHD. So treatment of all, so in this study, it was shown that if we are not using any, so if the population is of high risk, and also if the dose of T cells is high in the component, then if we are using leukoreduced product, still the risk is there. In gamma irradiation, the risk is reduced with the use of pathogen reduction and leukoreduction, this risk is decreased to minimal. So treatment of all these cellular components transfuse obviates the risk in immunocompetent patients and in those with unclear degree of immune system impairment. So so it would also depend on the immune status of the host as discussed. So in competent hosts, the risk is low, but it is unclear if the immune status is unclear or if it is compromised, the risk is high. And using irradiation and also using pathogen reduction technologies, so the risk of TAGVHD can be reduced. So this is from the same study in which they have compared two different technologies, that is gamma radiation and intercept, that is the amatoxylin with UVA. So in this, uh, they have used peripheral blood mononuclear cells which are obtained from a single donor through leukapheresis. It was subjected to gamma radiation, and another lot was subjected to intercept technology. So after treatment, they have seen that intercept consistently inactivated the T cells to a level of detection that is greater than 6.2 log, whereas gamma radiation inactivated at a log of 4.2 but less than 5.2. So in higher dose, the gamma was ineffective as compared to intercept, which was effective even at a log of 6.2. So these are various studies for TAGVHD cases, which have occurred in mild atypical symptoms or severe less clinical course, but they have occurred in patients who were not suspected to have any immunocompromised status, and thus the products were not irradiated. So still the TAGVHD has occurred. So then coming to there is a recent systematic review for TAGVHD in blood. So they have shown that in patients with TAGVHD, then 65.2% patients had no diagnosis that was conferring an immunocompromised state. So thus the product was not irradiated or pathogen reduction technology was not used. And they have suggested various data that should be included in future reports that should be documented for TAGVHD occurrence to come to a diagnosis of TAGVHD. Then coming to the summary, so transfusion-associated graft versus host disease is a rare and preventable disease that occurs when sufficient number of viable T cells are transfused into a susceptible host. Immunodeficient strains, either inherited or acquired, are well recognized risk factors, and it can also develop in immunocompetent patients. TAGVHD usually develops within days of transfusion, follows a fulminant course if it develops due to severe pancytopenia. Classical features are of GVHD only: fever, rash, diarrhea, and liver dysfunction. And irradiation of the blood component is highly effective, and pathogen reduction technologies can be the newer and more effective option for prevention of TAGVHD. There a word about transfusion-associated microchiasm. So transfusion-associated microchiasm is a condition that occurs when transfusion of cellular blood components in which a small number of donor allogenic lymphocytes proliferate within the host. They can remain detectable for years. And TAMC is associated with perhaps 10% of patients transfused after sustaining traumatic injury. So it is not affected by leukoreduction. And in approximately 10% of these patients, the chimerism from a single blood donor may increase the magnitude over months to years, reaching up to 2 to 5% of the circulating leukocytes. So it is the distinguishing the factors that influence T lymphocyte engraftment sometimes result in severe disease, and sometimes it results in no disease. So it is subject of ongoing investigation, and this may lead to downregulation of the recipient immune response, resulting in tolerance. So the reaction would not occur. So microchiasm would also result in release of various factors that mount a Th2 lymphocyte response, so that inhibit the production of Th1 lymphocytes and deactivate the cytokines, so the allograft is not rejected. So a number of units of blood transfused in trauma patients. So despite the trauma severity, gender, and proportion of patients who had underwent splenectomy was not different among those patients who did or did not have TAMC. So these factors did not differ in both the patients. So the diagnosis is by several techniques: PCR, then DR panel, and DL-based assay, which is frequently used. So I'm not going into the detail of this. Then transfusion-related immunomodulation. So, so the transfusion is immunomodulation. So we'll discuss the definitions, alterations occurring due to ABTS, mechanisms of TRIM, populations at risk, clinical effect of TRIM, both beneficial and dead risk. So what is transfusion related immunomodulation? So it can be defined as a variety of laboratory immune aberrations that occur after the allogenic blood transfusion and their established or purported clinical effects. So it would include both immunomodulatory, pro-inflammatory, and anti-inflammatory effects. So all these effects can occur, and allogenic blood transfusion may either cause alunization or it can also induce tolerance. So the presence or absence of autologous HLA-DR antigens on the donor's WBCs play a decisive role in this. So if there is a fully mismatched HLA-DR, alunization would take place. So then at least one HLA-DR antigen is shared, tolerance can occur. So what are the immune function alterations which can occur with allogenic blood transfusions? So there can be a decreased T helper cell CD4 count, decreased helper suppressor CD4 CD8 T lymphocyte ratio, decreased lymphocyte response to the mitogens, reduction in delayed type hypersensitivity. So basically the immune system is being decreased. The decreased natural killer cell function, B cell activation, T cell activation, decreased cytokine production, suppression of the lymphocyte, blastogenesis, and decreased monocyte and macrophage phagocytic functions. So what are the postulated mechanisms? So various mechanisms have been reviewed in literature: clonal deletion of specific lines of immune cells, induction of suppressor T cells, suppression of the natural killer cells, polarization of responses to Th2 with suppression of Th1 response, selection of non-responder type of immune cells, mixed microorganism. So microorganism is also involved in TRIM, induction of apoptosis, resulting in death specific type of immune competent cells, accumulation of various supernatant stored blood components of these soluble molecules that would be in the plasma, that is histamine, eosinophilic cationic protein, eosinophilic protein X that inhibit the neutrophil function, accumulation in supernatant of the stored components of soluble molecules. So we'll be discussing all these. So basically, allogenic blood transfusion would have leukocytes, so which have a effect that is being postulated as transfusion-related immunomodulation, which can be pro-inflammatory, inflammatory, or immunomodulatory. So red blood cells, if leukocytes reduced by filtration, still have 5 into 10⁶ leukocytes. And if we are using red blood cells that are not leukoreduced, that would have 10⁶ to 10�7 number of leukocytes in the unit. So leukocytes would also be there in platelets. They use random, and apheresis platelets would have leukoreduced B. So these are the criteria for leukodepletion. So American Association says less than 5 into 10⁶ WBCs per unit. European Council says less than 1 into 10⁶, and our DGHS criteria is less than 5 into 10⁶ per unit. So what are the various mechanisms that have been postulated for TRIM? So after the allogenic blood transfusion, there are allogenic WBCs. There are soluble biological response modifiers, and there are soluble HLA peptides, and ABT itself predisposes to infection. So all this will either lead to a pro-inflammatory response or down-regulation of the recipient's immune system. So another mechanism associated with TRIM is so between there's a donor dendritic APC. So these are the antigen presenting cells in the donors. So there are soluble HLA, and in the recipient T cell mounts a response. So if the response is mounted, then the immune activation take place as the new antigen is not recognized. And if the HLA-DR on the donor dendritic cells is matching with the recipient, so then microorganism and immunosuppression will take place. So recognition by the recipient T cell of the HLA-DR antigen, so which would cause an immune suppression and allograft tolerance. So based on these mechanisms, the beneficial and deleterious effects of immunomodulation can take place. So discussing the various causes. So HLA class 1 peptides that circulate in the allogenic plasma, then soluble biological response modifiers, which would be released in a time-dependent manner, that is WBC granules on membranes into the supernatant fluid of red blood cells or platelet concentrates during storage, and allogenic mononuclear WBCs. So white cells and platelet-derived so there are various bioactive substances which can be there. Basophils, like they have histamine, serotonin, tryptase, plasminogen activator. Then eosinophils, they have eosinophil protein X, cationic proteins, peroxidase. Neutrophils, these have myeloperoxidase, vascular endothelial growth factor, vascular endothelial growth factor receptor. Platelets have plasminogen activator inhibitors, tissue inhibitor of metalloproteinase, vascular endothelial growth factor. So all these have been postulated for various TRIM mechanisms. So this is another review in which mechanisms of red blood cell transfusion-related immunomodulation was studied. So they found that WBCs, they can be either intact WBCs or soluble fast ligand, then transforming growth factor beta and HLA molecules. RBCs could have cell-free heme, iron, ubiquitin, and platelets could have bioactive lipids and extravascular cellular vesicles. So these are both soluble and insoluble mediators. So these would cause the recipient immune cells to lead into an inflammatory effect or an immunosuppressive effect. If it's an inflammatory effect, it would lead to alveolization, neutrophil activation, monocyte activation, and inflammatory cytokine release. If it's an immunosuppressive effect, it would lead to increased anti-inflammatory cytokines, then decreased monocyte macrophage cytokine production, so decreased immune response and tolerance and T cell energy. So this is just a diagrammatic representation of transfusion-related immunomodulation. What's in our blood? So it has red blood cells, white blood cells, platelets. Apart from these, storage and processing can cause various immunomodulations. Bioactive lipids are there. Extravascular cellular vesicles are there. Then TRIM would also depend on donor characteristics and recipient characteristics. So what are the various biological response modifiers? So I have discussed earlier also. These include histamine, myeloperoxidase, eosinophilic cationic protein, plasminogen activator inhibitor. So these increase from 3 to 25 days of the storage. So they increase 3 to 25 times over 0 to 35 days of storage. So they have been shown to decrease neutrophil function, thereby contributing to development of immunosuppression. So various soluble HLA molecules. So these are mainly from the liver and are there in the supernatant fluid of RBC and plasma. Non-HLA class might be antigen, non-specific immunosuppression. Then it also seems possible that allogenic plasma containing the soluble antigens may enter the recipient's thymus and produce clonal deletion of the recipient T cells. So the immune response would not be mounted. Then fast ligands present in the soluble part of the plasma. So these cause the fast receptor blockage. So once the fast receptor is blocked, so expressed on the natural killer cells and cytotoxic T cells of the recipient, this would impair the function and impede the apoptosis of the viral infected cells. So this can be a deleterious effect. Then factor VIII concentrates, if they are given, they reduce the induction of T cell activation molecules. Then autoantibodies. Some donors have large amount of the neutralizing autoantibodies to a number of the growth factors like granulocyte, macrophage, colony stimulating factors, and cytokines. So this would have an anti-inflammatory effect. Then these antibodies would neutralize the cytokines of the recipient, leading to a transfusion-related inhibition of the cytokines. So anti-inflammatory function. And TRIC may also increase the susceptibility to infections. So then apoptotic WBCs, even the broken WBCs can be a factor which can provoke the TRIM. So there may be two categories in this: HLA dependent and directed against the adaptive immunity, and non-specific directed against the innate initial immunity. The non-specific effect might result from infusion of WBCs that undergo apoptosis during storage. So what occurs in once we store the blood? So WBC apoptosis would begin immediately after blood withdrawal with granulocytes, then monocytes, while lymphocytes will remain viable. So these apoptotic cells, they engage the receptors on the macrophages, and they release anti-inflammatory molecules, which would suppress the macrophages and natural killer cells and impair the antigen-presenting cell capacities of the recipient. So this is a review article which shows various responses that occur when when we refrigerate these cells. So donor APCs, the normal responses, the MHC2 on the donor APC and the B molecule on the APC, they present various to the recipient T cells through CD28 receptor and T cell receptor, which would cause an effector T cell receptor in the T cell to mount a response in the recipient. And if the refrigeration has taken place, the refrigeration would cause by two mechanisms, either reduce expression of B7 molecule, or uh, the B cell molecules inside dissociating the CD28, they will stimulate T lymphocyte associated protein 4 CD4 molecule. These would an energetic T cell response. So this is how the suppression of macrophage function is taking place. So donor dendritic cells, they interact with the CD200 molecule on the T cells. These would release the transforming growth factor beta from the recipient T cells, which would suppress the macrophage function. Then, so these are fast ligands which are present in the soluble part of the plasma. So when these are infused, these would interact with the fast receptor on the natural killer cells of the recipient or the T cells of the recipient. So they would not so the recipient T cells will not be able to mount a destructive response to the infected cells. So they would not undergo apoptosis, so which can lead to infection. So effect on WBCs on the storage. So I've discussed this 3 to 5 days of storage. So protein synthesis, the responder capacity would decrease, and donor APCs, so the capacity to stimulate the recipient T cells would decrease. So who are the vulnerable populations in which these stream effects can be noted? Post-operative patients, trauma patients, sepsis, cardiopulmonary bypass, transplantation, and in pediatric population. So what are the various clinical trim effects which can take place? So there can be increased recurrence rate of resected malignancies, increased incidence of post-operative bacterial infections, activation of the endogenous CMV or HIV infections, and increased short-term mortality. So various RCTs have taken place which have shown these effects. I'll be discussing. So beneficial effects can be enhanced survival of renal allografts, reduced risk of recurrent spontaneous abortions, and reduced risk of Crohn's disease. And deleterious effects, as I've discussed, recurrence of malignancies, increased risk of bacterial infection, increased short-term mortality, especially in the cardiac surgery, and increased risk of reactivation of CMV and HIV. So these are various studies which have shown the main effects of transfusion-related immunomodulation. So 2 or 3 studies have shown increased transfusion-related mortality. Others, they were not able to conclude. Then RCTs have been there for trim effect from the RBC product which has been given, and whether it is depleted for allogenic WBCs and or allogenic plasma. So various RCTs which have usually used Buffy-coat reduced allogenic RBCs as well as allogenic whole blood, which is not WBC reduced allogenic filtered after the storage. So some have showed no difference, some have shown higher risk of post-operative infection, but not of cancer reoccurrence, and some have shown higher risk of again post-operative infection. So they are not able to conclude definitely what are the possible effects, whether it is having any beneficial effect or it is having any negative effect. Then, so the beneficial effects which have been shown in some studies are enhanced survival of the renal allografts. Pre-transplant allogenic blood transfusion enhances the survival of renal allografts. Then it is less important when immunosuppressive agents are being used. Patients who receive allogenic blood transfusion have shown to have significant better allograft survival. Then beneficial effects of ABT was found to be independent of the age, gender, and underlying disease. But this has not been observed in various other allografts like pancreas, skin, or heart. So in cardiac surgery, there is a postulated mechanism which was discussed in an article where cardiac surgery takes place. There is a ischemic reperfusion injury. So then systemic inflammatory response syndrome occurs, which can lead to infections, then multi-organ damage and mortality. So this is a deleterious effect if we are using allogenic blood. Then reduced risk of spontaneous abortions. So the fetus would represent a semi-allogenic graft to its mother, and maintenance of a pregnancy would depend on the immunological equilibrium between the fetus and the maternal immune response. So when the genetic parent would share the HLA antigens, this balance may alter the predisposing pregnant woman to the recurrent spontaneous abortions. And to prevent this, transfusion of allogenic WBCs have been proposed as a form of immunotherapy. So they have a beneficial effect. So what all WBCs can be given? Pooled Buffy coats, single donor Buffy coats, then RBC suspension containing the WBCs. So reduced risk of Crohn's disease. So pooled data from existing studies which are taking place suggest recurrence rate in transfuse versus non-transfuse is almost similar, and role of perioperative ABT in modulating disease activity in Crohn's disease. So this needs to be investigated further. So there are various deleterious effects they have been studied, like increased recurrence of resected malignancies. So the host immune response to tumor controls the tumor's growth. Allogenic blood transfusion may cause impairment of host immunity. It may facilitate tumor growth. Then meta-analysis of more than 100 observation studies found a statistically significant adverse clinical outcome among transfused patients and were compared with the untransfused patients. So cancer recurrence, possible recurrence of cancer by allogenic blood transfusion has been examined in 100 observational clinical studies and 3 RCTs, and no adverse TRIM effect on cancer recurrence has been detected. Then association of, so this is a review article which showed various RCTs that have taken place till date. Then association of the WBC transfusion to the cancer recurrence. So only one study which favors autologous transfusion or WBC reduction. So which would which has favored that allogenic blood transfusion, if it is not given or if WBC reduced products are given, so it would prevent the cancer recurrence. So then this is a postulated mechanism for cancer growth and dissemination. So when red blood cells are given, residual leukocytes and apoptotic cells are there, which would cause the TNF beta and other cytokine and biological response modifiers, extracellular vesicles and microparticles, basically platelet microparticles, and vesicles bound and free HB. So this would lead to various TRIM effects which can lead to cancer growth and dissemination. Coming to post-operative infections, so over 20 RCTs and approximately 40 observational studies had compared the risk of these post-operative bacterial infection. So no effect to many-fold increase in the infections in the allogenic blood transfusion is there, and no significant association between outcomes of patients that received allogenic blood versus those that did not. So it may be associated with multi-organ failure. So in this is a multivariate analysis of transfusion independently increased risk of the ventilated isolated pneumonia with transfusion. So it has shown that in red blood transfusion, if it takes place in ventilated isolated pneumonia, it can be an increased risk factor for these infections. Then association of WBC containing allogenic blood transfusion with post-op infections. So various RCTs, these have shown favorable effect. Some have not shown any favorable effect. So increased risk of mortality, short-term mortality between non-WBC reduced allogenic blood transfusion and mortality. So non-WBC reduced allogenic blood transfusion would predispose to multi-organ failure and hence increased mortality. This has been shown in various RCTs, and most evidence suggests that tissue injury is mediated by reactive oxygen species and proteolytic enzymes that are released from the activated neutrophils. So these are the RCTs which have shown a favorable response if we use autologous blood or WBC reduced blood, so the short-term mortality decreases. Proposed mechanism for non-WBC reduced allogenic blood transfusion and multi-organ failure. So when we are using a pre-storage, when pre-storage WBC reduction is not there, titrating WBCs can be there in the RBC that act on the RBC membrane to produce bioactive lipids. So which will lead to neutrophilic priming, endothelial cell activation, thus leading to superoxide production and enhanced cytotoxicity. So a pro-inflammatory effect, and which can be deleterious. So these are various RCTs which have shown WBC containing allogenic blood transfusion with all-cause mortality. So the RCTs have shown a positive effect that if WBC reduction is there, so the all-cause mortality decreases. So in ICU patients, given mixed results of both preclinical and clinical study, it is tempting to conclude that TRIM does not exist, or if it does occur, the effects must be small compared to the insults the patient face in the ICUs. So what about if we are using leukoreduced blood? So though it has effects of preventing HLA immunization, transmission of CMV, Epstein-Barr virus, and bacterial parasite contamination, pre-storage leukoreduction may help in abolishing the TRIM. But in clinical studies, only post-op cardiac patients have demonstrated a benefit in reduction of the post-op infection. And even in this setting, the reasons of excess deaths attributed to WBC containing allogenic blood transfusion, the cause remains to be found out. So then these are various studies which have studied the TRIM prophylaxis. So whether we are using non-leukoreduced blood to leukoreduced blood, or we are using leukoreduced pre-storage leukoreduction to post-storage leukoreduction, or Buffy-core depleted red cells. So various studies have shown different effects. So this study has shown infection and mortality, it decreases with leukoreduced blood. Then no difference was observed between two techniques in this study. Then this double-blind randomized controlled trial, it has shown mortality twice as high with Buffy-core reduced and lower infection rates with pre-storage leukoreduction. This has again showed infection leukoreduced as greater than allogenic autologous blood transfusion. Other studies have shown no difference. They had used non-leukoreduced versus pre-storage leukoreduction. So it is difficult to study the TRIM basically because numerous observation studies, they have shown insufficient perspective. There are various insufficient basically the RCTs are less, and likelihood of confounding factors are there. Whether patient is receiving transfusion is different from those who are not receiving transfusion, and widespread introduction of universal leukoreduction has decreased the opportunity to perform these RCTs. So coming to the summary for TRIM. So TRIM results in at least one established beneficial clinical effects and various other unconfirmed deleterious effects. And it remains unclear whether deleterious clinical TRIM effects of ABT truly exist and whether they are mediated directly or indirectly by allogenic WBCs. In theory, pre-storage WBC reduction may lead to prevention of these TRIM effects, but it still remains unproven that leukoreduction would improve the mortality and morbidity. So the available RCTs have not demonstrated a benefit from autologous transfusion in preventing the adverse TRIM effects. So with this, I come to the end of my presentation, and I thank all the participants for patience listening.
Thank you, Dr. Divjot, for excellent talk. Can I request Asim sir to moderate questions? If you want, I can read out the questions from the chat box.
Yes, Ankit, please do.
Okay, sir. As of now, I can see two questions. One is, what's the reason that irradiation is not required for frozen or thawed RBC? Question is from Dr. Puneet.
Dr. Divjot, would you like to respond to this question?
Thawed RBCs would have, frozen RBCs basically would have, the T lymphocytes would have been destroyed, and so the irradiation is not required post thawing, according to my knowledge.
I agree. So there would be no viable lymphocytes which can cause this because of freezing and thawing. What is the other question, Ankit?
Another question is, why is HLA-DR antigen so significant?
HLA-DR antigens have been postulated in the mechanism for TRIM as well as the microchimerism, which is also important for the TRIM effects. And they have been studied, various studies have shown that these HLA-DR, the molecule on the donor T lymphocytes, so it is postulated for causing the in, decreasing the inflammatory response when the recipient recognizes this HLA-DR.